All right, welcome to the Spine Conference. So today's discussion will be, and you can interrupt me anytime you want. Will be spinal stenosis, revision, fusion, decompression, and an infected non-union of the spine. So I feel compelled to go over the whole story, just so you understand everything. So this man has had 3 surgeries, and the last one was got infected non-union. Actually, he had 5 surgeries, but he had a decompression fusion and revision fusion. But I'll go over everything. This is not him, but he looks something like that. He's a 56-year-old male, right sciatica. He had symptoms for 2 to 3 years, and the pain radiated to his lateral malleolus. He was relatively healthy, GERD, hypertension, no medicines, which is unusual. And he was a retired property manager, avid hiker, and outdoorsman. He's a very robust guy, strong guy. He retired early. He's one of these financial independent retire early people. Have you heard of that FIRE? That for young people, it's like save all your money, retire early, and then sort of like enjoy life. Yeah, without working. That's not our generation.
That's not our mindset. No.
So I wanted to go over this. I know you know this, but the dermatomes and typically, I think the lateral malleolus is the L5 nerve root. And the L4 nerve root is lateral knee, and the front of the thigh is L3, and S1 I think is like heel, calcaneus, lateral border of the foot. Mm-hmm. Do you have anything to add to that, or?
Just that sometimes people present a little atypically. Sometimes L4, which causes both anterior thigh and shin pain. Sometimes L4 may look like only anterior thigh pain. Sometimes one can have a partial.
So like variable penetrance sort of the symptoms, yeah. And also they can be off a nerve root, like L5 acts like S1 sometimes. Yeah. So do you think L3 acts like L4?
Like a prefix plexus or, yeah.
Okay, so here's his MRI scan pre-op. This is 2019. And he had L5 was a nerve root I was worried about. And what do you think of L4, L5?
Yeah, I guess I'd call it moderate spinal stenosis centrally. We could look a little higher or lower to see the foramina, but there's definitely moderate stenosis there. 4-5.
Okay, so I thought 4-5 was the main actor, but I wanted to be sure that his L5 symptoms went away. And I thought there was some hypertrophy of the L5-S1 facet, so I thought the L5 nerve root could be caught there. So I just wanted to review. I know you know this, but I thought other people would be here. But we'll just go over a normal MRI. You have the disc, the psoas, the traversing L5 nerve root. There's some fat, ligamentum flavum, the lamina, and the exiting nerve root with some perineal fat. That's like a normal MRI. And just one more, I really like this description in 2011 of lumbar stenosis. And this paper characterizes it as: is there cerebral spinal fluid anterior to the nerve roots? Are the roots separated? Is there space between the roots? Is there epidural fat? I think all these things help understand the nature. So this is just non-operative treatment of is steroids.
Where'd you get that picture of me?
I snuck it at your last competition. Steroids, nonsteroidals, neuroleptics, amitriptyline, muscle relaxers, basically to get people over the symptoms. And I give a lot of nonsteroidals, and the most common side effect is stomach upset, but you can have GI bleed, renal failure, hypertension, risk factors. And I usually I frequently do the decompressions through the ULBD approach, unilateral laminotomy, bilateral decompression. So through one side, decompress the spinal canal, tilt the table, and decompress the other side, but just a unilateral approach. So that's what this first surgery was. ULBD, unilateral laminotomy, bilateral decompression at L405, and on the right at L5S1, a laminar foraminotomy to make sure the nerve root was free. Patient sciatica was gone, but he had a lot of symptoms post-op, and he went to the ER, unbeknownst to me, for low back pain. And now it's common to get an MRI scan in the emergency room. It used to be unheard of, but you can get it. So 3.5 months post-op, he did get an MRI, which was basically normal. And I just found this article in 2013 about early postoperative imaging after lumbar decompression surgery. So this was 28 consecutive patients who had a decompression, and then everybody got an MRI. And 2/3 of those patients had moderate to severe stenosis and no symptoms. Patients felt fine. So it's just the MRI post-op. I thought it was interesting, and it's true. It's very difficult to interpret. I mean, what are your feelings about immediate post-op MRI?
I rarely do it because, like you said, the post-operative changes are harder to differentiate from a potential recurrent disc herniation.
Or
Also,
or hematoma.
Or
It could just be
hematoma.
fluid.
Fluid is
Right.
normal. I mean, I guess you can tell if the fecal sac is deformed with the fluid, which is more of a concern than if there's just fluid without deformation of the fecal sac.
But I think every surgery there's a void, and blood fills the void.
Yeah.
So
You're going to have fluid always.
there's always going to be some blood.
Yeah.
So it's very difficult to interpret. So mostly I go by symptoms.
Yes.
The patient's out of control pain and there's a hematoma.
Yes.
It's rare, but you can have a normal MRI post-op, in which case that holds your hand. I'm not going to do surgery if the MRI is normal. Okay, so I want to go over that. So 16 months post-op, patient still has persistent right, great, and left sciatica numbness. And this is his MRI, which shows, I thought L3, L4 was definitely stenotic, and 4-5, some lateral recess stenosis, and his symptoms were L5 dermatomal. He wanted surgery. He failed non-operative measures. So he had a revision surgery, basically revision decompression L4, L5, right L3, L4 ULD with L4, L5 fusion. He immediately did well, but then 3 months post-op, again, he went back to the ER.
Now, you didn't do not that I would have, but you didn't do a culture. Since it was a redo, should we be getting cultures and all redos?
I think maybe for non-unions, but for revision decompression, I don't.
Yeah, I wouldn't.
Do you?
No,
revision decompression? Yeah. No, but that's an issue. Once you have a surgery, there always can harbor an infection. So this 3 months post-op, the canal was pretty good.
Yeah.
I would have hoped that looked better, but
well, that's the thing. For 5, you achieved a great decompression because you were able to
fuse it. Yeah.
Fuse it, so you didn't worry about how much of a fascectomy you did. At 3-4, you're trying not to destabilize.
You're a little hamstrung.
Yeah.
Yeah. So some time goes by, 3.5 years post-op, and the L3, L4 stenosis worsened. And when I do these ULBDs, I see the arrows. The stenosis comes from medial to lateral, and centrally it's decompressed, but the facets keep growing from the disease process. So, and also a pre-op CT shows the facet is fused. You can see the facet on the sagittal cut, and on the axial cut, you don't see the facet line, the cartilage. He's fused at 4-5. So I took him back for a revision, L3, L4, decompression with L4, 5 instrument fusion, changed the screws. And initially he did extremely well. But he came back 2 months post-op because of severe incisional throbbing. And you see this MRI here? Look at this. He had a temperature of 102 Fahrenheit and severe pain. Yeah. So I thought I couldn't rule out an infection. So I washed him out, and he had methicillin-sensitive Staph aureus. Right. It was 2 months post-op. So 2 months post-op, when you wash out an infection, how do you do it? Do you always open deep? Do you wash out superficial fur? How do you do it?
It's almost always deep. It's a superficial infection to me is usually just like either a cellulitis or a little bit. But if you start getting a fluid collection,
there's pus superficial.
It's almost always deep.
The deep's infect. I agree with you.
I mean, I might look and see, is there a fascial tear or not? There almost always is a fascial dehiscence. But I would call it a low threshold to opening up deep. And I guess I would say that every single time I've opened it up post-op, I've gone deep.
Yeah, I agree. So I just wash out superficial, get the cultures, wash it out really good with half the 3-liter bag, and then I open deep, get a second culture, wash that out too.
Yeah.
Okay.
And retain the screws.
And retain the screws. Yeah. Because it's the early. I think even joint replacements, they retain everything now.
Right. For early on, yeah.
Yeah. So these are just the risk factors for infection. And so the question I'm always thinking are the implants infected? Like, is there a biofilm on the implant? So this is just a electron microscope of an infected screw with the implants, and the bacteria can lodge onto the screws, create a biofilm, which is polysaccharides, and it's very difficult to eradicate this without taking the screws out. So there's one more thing I want to add is what constitutes a fusion. How can you get a fusion? You need stem cells, you need bone forming hormones like bone morphogenetic protein, vasculature, and also a scaffold like calcium hydroxyapatite or allograft. So he comes back a year later after the uh, infection with low back pain. Now, mind you, he was doing very well. In fact, he hiked like 8 miles the day before he saw me in the office. He goes, "I feel good, except my back hurts."
Okay.
So here are what do you think of the screws here?
They're certainly loose.
Yeah. So no fixation there. And he's a year out, severe pain. So the issues at him is he has axial low back pain. I think there's a clear non-union at 3-4. Before 5 is fused, you see the lucency. L3 has no fixation. There's probably an infection deep, and he's a big guy. And the question is 1 or 2 stages, but we'll get to that in 1 second. So I just want to review a little bit of the literature I sent. Since we're orthopedic surgeons, we think about non-unions of a long bone. So this is a review article for all infected non-union of long bones. You debride the infection, remove the implants because they're probably colonized. You fix the long bone with X-Fix or something provisionally, or you could do a cast. You give the antibiotics some time, either intravenously by mouth or with beads, and then you refuse it after a period of time, right? Like 2 months. Would you add anything to that? Or not? This is long bones.
Yeah, those
are the basics. Okay. So this I sent this to everyone because this is from 2018. This is strategies for prevention of infections, so things to learn from. And things that cause infections are dirty scrubs, C-arm cover. Apparently, touching the microscopic eyepieces contaminates your hands. Apparently, changing your gloves before handling the screws decreases your infection rate from 3% to 0.5%, which actually I don't do, so I'm going to start doing it, I think.
I've never heard of anyone doing that, to be honest. It's interesting. It's a very easy thing to do. Right?
Yeah, and it comes from the total joint replacements. A lot of people do that. So I think I'm going to start doing that, changing my gloves.
Especially in spine, because by the time we're ready for the implants, we've already been operating for
it's been some time.
To 2 hours.
And your gloves are usually full of blood, dried blood. Iodine irrigation for big cases, like at-risk cases. And the Rothman Institute does 30 cc's of the 10% iodine you find in the scrub kits and dilute it 1 liter. That makes a 0.3% solution. Let it soak for 3 minutes.
But what, the instrumentation?
No, the wound.
Oh,
so at the end of the case, 30 cc's of iodine from the scrub kit in a liter. Let it soak for 3 minutes. That decreases your infection rate from 5% to 0.3%. Come on in, guys. Vanco powder, which is kind of been proven. Cement impregnated beads, and they have the stuff that's absorbable. Welcome, come on in. Tobra Gent for the beads, negative pressure dressings. You want to add anything to that? Like things that you can do to stop infections?
This is for prevention.
I
think there's increasing data about preoperative nutrition support.
Yeah, especially elderly people. Okay, so this was a meta-analysis from Hopkins of removing the implants with infections versus keeping them in. And removing them had significant problems. So you do the washout and remove the implants so you don't have the glycocalyx. The people who had removed the implants, the studies where they removed the implants, there was a higher non-union rate and a higher death rate. So the problem is removing the implants is you have no stability in the spine. This is what you were talking about. When you do a non-union, you culture the non-union. And this was a case of 128 revisions for non-union. 10% had positive cultures. So it's basically an occult infected non-union. And those people had a much higher revision rate. So it's not good to have an infected non-union.
Yeah, I find this very interesting because one of my previous older partners always used to say that when he had spinal infections, that after the infection clears, he believed that fusion rates were augmented. That he always saw robust fusion after infections.
Yeah.
I never saw that in my practice over the years.
That's an
But
old
what
school. Yeah, that's an old school mentality, and they used to call it laudable pus. So you do a surgery, and the patient will get infected, which is good because it leads to a fusion. That's what they used to say.
Right. But this study says the opposite, and in my experience, I agree with the study.
I agree too. Yeah, infection is a risk for non-union.
Is a risk for non-union, right?
Yeah.
I think that surgeon probably just, at the time of his washout, he just probably did a good job at decorticating and ensuring that devitalized tissue was gone so that he increased the vascular supply. So whatever he was doing to treat the infection may have helped fusion, but it wasn't the infection that helped the fusion.
I don't believe it.
Who knows? Okay.
Yeah. So one more thing. This is from China. This is they reviewed 139 fusions, and 16 out of the 139 got infected. And then they observed those infected patients that had washed out, and the non-union rate was 72% versus 18% for everybody. So this is kind of proves the point that if you have an infection, there's a higher non-union rate. And this is just another article of when you have an infection, inserting cement beads with antibiotics, it increases the success rate to 87%. Okay, so back to our case. So it's an infected non-union, and at L3, L4. So the questions are, do you take out all the implants? Do you do it in one stage? Do you do it in two stages? It's a big guy. It's like a very muscular big guy. So it's not easy. The surgery is a little difficult. So what are your thoughts, Oren?
It's challenging. I mean, one could remove the L4 and L5 screws. You're solidly fused across the facets, certainly. The L3 screws have to be removed. They're not doing anything. They're not providing any stability.
They're not providing anything with this. When you have that big of a hyaluronic, it's not doing anything.
So you take out all the hardware, you wash it out.
He has no radiculopathy also.
Okay, good. So you
just low back pain.
Don't necessarily need to explore the nerve roots aggressively.
Spinal canal, yeah.
But the question still is, which I'm trying to duck, I guess, by
you don't have to answer. You don't have to answer it.
The question is, do you put in bigger screws to stabilize?
How do you stabilize L3? Yeah.
I mean, a bad idea, I think, is to go up to L2, skipping L3. I don't know if it's a bad idea. An idea would be to put
That's what I did, by the way, so don't hammer it too much.
Well, no, I first said that because, let me explain.
It adds another level to the fusion.
Adds another level to fusion, and maybe are you going to introduce infection to a L2 that wasn't infected? So that was why I first said bad. But then, you
okay.
want to stabilize it.
It's okay. There are risks associated with this. More surgery, a stiffer construct for the patient.
Bigger screws into L3 where it's already infected. That's probably a bad idea.
That's a 6 millimeter screw. So I mean, I don't think you can get a screw big enough to work. All right, so yeah.
Before you move on,
one more thing is I'm recording this so everybody knows. So it's I'm posting it. So everything for everyone. Go ahead.
The lucency or the haloing on your MRI images in the middle and off to the right.
Yeah.
Is that the biofilm you're referring to? When you say biofilm on implants?
What do you think, Warren?
No, biofilm is more of a microscopic thing. The bacteria form this.
Biofilm. So biofilm you see on it lodges in the crevices of the screw and it covers it with the glycose. So it's hard to rid the infection with just antibiotics alone, if not impossible.
The haloing around screws, I think, is more non-union.
Non-union.
Or just a bone infection?
I think it's from motion from the non-union. So
gotcha.
when you move, every time the patient moves, it erodes the bone. And it's so eroded now that the screws aren't doing anything.
Yeah, I think the salvage strategies is either a two-stage procedure, take the screws out, wash it out, come back later to stabilize it, or to go up to L2. I don't know that.
So if you stage it, there's a better chance of clearing the infection because you get everything out, hammer the patient with antibiotics, and then when you put the screws in, hopefully it won't recur, right? That's the whole point. But when you do it in one stage, did you get it all out? Did you get all the infection out?
So I think it's a tough call. I don't know that the literature points definitively in one direction or another.
It doesn't, and also, but the total joint replacement literature and long bone literature is better than 2 stages. You clear the infection. But the problem is you can't stabilize the spine.
Yeah.
Like a brace doesn't work very well.
And you can't just put a
Without
cast on the leg
implants.
and
Yeah.
have them bear weight on one leg, and you can't do that for the spine.
Right, and you can't put an external fixer on the spine, although people have done that in the past, but it doesn't work very well. Okay, any other questions or comments? Okay, so I decided 2 stages, and I used stimulant, cement, resorbable antibiotic beads, calcium sulfate. I inserted 1 gram of Vanco and 240 milligrams of Toba, which are not heat sensitive. So I'm gonna treat the infection with like both spectrums, and then my original plan was not to remove the screws and put nothing in there but beads, but it was so deep and so much scar. I thought to myself, it's going to be really hard to get these screws in again because it may heal in. So I took the old screws out. I put in new screws as sort of place markers. So I just put in new screws where the holes were just to hold the place of the hole so that it'll make the revision fast. Because you want to do surgeries as fast as possible, obviously, without being sloppy. But I felt it was worth it. I mean, you are introducing more metal. Maybe the infection will get into that. So that's the downside, I thought, that the infection will not be cleared because of these screws. But then it's probably going to save me an hour in operative time.
Well, it's more than just time. I think putting in screws, we do it so often, we think it's nothing, but it's actually very technically challenging to put in screws. And if you don't have normal anatomy, it's actually much more difficult.
It may not go well. Yeah,
makes sense. It's an interesting idea.
So I mean, the other thing I was put a K-wire. I don't put a K-wire because then I don't know. I think
just something sharp now.
Yeah, just put this. So that's what I did. So, and I treated him for 6 weeks of.
That's an opportunity for us to develop a new product. Replace a screw made out of
cement
with antibiotics. Yeah,
like they have in total joints.
Yeah.
Yeah. Okay. There was a non-union. So then I treated him. So he's walking around basically unstable, and he felt fine. He had remember Max? He had no radiculopathy symptoms. So, I mean, how long do you treat? When do you take him back for stage 2? What was it? What do you think, Warren?
I would say at least 2 months.
I did 6 weeks. I did 6 weeks.
Yeah, you can follow labs, CRP, SR, but.
Oh, there's one more thing is that after post-op, after you do a surgery, when does the white blood cell count, CRP, and SED rate normalize? Anybody know the number? I'll give you either 7 days, 21 days, 1 day. Would you guys? You should get it with that spread. So 7 days, yeah. Max and I like to play these games. Okay, so I took him back. 6 weeks post-op, and the question I had was what to do about L3. Like, can you instrument L3? And I didn't think you could standard manner. So there were 2 options. One is fenestrated screws, where through the screw there's holes in the end of the screw. You can insert cement. You can see what it does. It gives you some stability. It takes time though. It's not fast. The other thing is like a total hip replacement. We've all done total hip replacements. You just insert cement in the stem, and then you put the screw or the implant in. So that was like a lot faster. That's what I decided to do, just to make the case go quickly. So I removed the placeholder screws, reinserted screws, put some cement in these, and then I did what Oren said I shouldn't do. I went up to L2 because I wanted to be sure of the fixation, and I didn't want him to fail again. Like, having him fail would be a big problem. Mm-hmm. The other option that I didn't consider was an XLIF at L304. I mean, I really don't do XLIFs, but that's another option for stability. So this is his post-op standing film, 4 months post-op, and basically pain-free. And in fact, before he saw me, before 4 months, he said he had traveled to Moab, Utah, and he did like a 10-mile hike or something. I mean, but he's like, I'm not sure that has anything to do with my success as a surgeon, but rather this guy's like really rugged individual.
Look at the thick lateral gutter fusion you have at the 3-4. And we just saw papers saying that infection decreases fusion rate, but I put
allograft and I put a large infuse. In this case, so it would basically throw the kitchen sink and the whole thing, get it diffused. So that's all I have today. So any questions or comments? Non-unions of the spine. See him back in like 6 months or something.
When you did the L34 fusion prior to the infection, did you use iliac crest? Because I see there's iliac crest from graft from one of the surgeries at least. Because I've seen.
Did I use crest on this surgery?
Well, not with the last one, but with
I used
one
crest
of them.
on this one. I used crest on this one.
Okay, yeah, on this one.
Yeah.
Sometimes when I see spinal infections after posterior fusion, the infection goes down to the iliac crest, and so I ask the question: did the infection start at the crest, or start in the spine and move to the crest? And that,
is the crest involved? Yeah. I did a right crest. I did right crest on his first fusion, and then the second fusion I did left crest. So the right crest was kind of normal. What I do is after I take the iliac crest, I backfill it with allograft, and within a year or two, that thing's normal. So it was basically normal.
And when you had the infection, when you washed out the infection, you didn't see any tracking to the pelvis or anything?
No, I look, but I don't go crazy about it because then you introduce it. So
it's obvious if
it's a track of pus, yeah. And then I poke in the fascia and see if it looks like loose or infected. What other questions? Any other questions or comments? Infected non-unions?
Did you have to upsize your screws on the L3?
No, I didn't because I just did cement. I filled it with cement. Did I put sevens? I can't remember. I may have put a 7. I think not by a lot, but it was a big hole. So I'm basically counting on the cement to give me fixation. But I also went to L2, so it's probably okay. The fixation's probably strong enough. I added a level to his fusion on this, unfortunately, but I don't know.
I don't know the functional changes here. He was able to be very functional afterwards.
If the patient fails, it's a big problem. Yeah. This guy's been through a lot, so he wanted it to. I talked to him about it, and he says, "I don't want to ever come back." He goes, "You know what the patients always say. I really like you, but I never want to see you again." They always say that. All right. What else? Any other questions or comments about infected non-unions, Oren?
You're trying to treat the infection, but you have to think about everything. I think paying attention to sagittal alignment is important here. You have good lordosis sometimes, especially if there's discitis involved with an infection. You need to consider that and reestablish lordosis if you lost lordosis with an infected disc, perhaps, or if there was bone deterioration, osteomyelitis of the vertebral bodies. If you lose lordosis, that also would have to be addressed.
The Jackson table gives lordosis, with the patient like flat supine, but that wasn't an issue for him. He had no collapse.
Yeah. It's just worth thinking about.
Every degenerative, look at 4-5 right there. 4-5 has lost a lot of the typical lordosis, and his 5-1 disc is normal. Most of the lordosis comes from 5-1, so that's why that's not so much of an issue. But everybody's fused in flat back because L405, L5S1 is the most common fusion we do, and that's where all the lordosis is, and it's very flat. So it's very difficult to get the lordosis back. You really have to work on it, inserting a graft anteriorly and squeezing down. It's not easy. All right, what else? What other questions? We good? All right, thanks for coming, everybody.